and also worked in the CDC regional antimicrobial laboratory, working on high complexity testing for C. auris and some of the response for the states involved. So glad to be here, welcome. And as she said, I work for the Bureau of Healthcare Quality and Compliance, which is a regulatory entity. It has an infection prevention and control team that helps healthcare facilities implement their infection prevention and control plan by providing recommendations from nationally recognized standards. The objectives today are to increase knowledge and understanding of C. auris, be able to identify risks, know the role of infection prevention and control of C. auris, increase staff competency in implementing recommendations, and be able to detect and respond to gaps. And by the way, we have noticed there are some distortions with the PowerPoint because they're different versions. So I believe since this is a different version, some things are going to be cut off. So I apologize for that in advance. Multi-drug resistant organisms are a healthcare associated infection, or HAI, and on any given day, about 1 in 31 hospital patients have at least one healthcare associated infection. And when I refer to patients, that includes residents unless otherwise specified during the presentation. Antimicrobial resistance is a leading cause of death worldwide, killing 1.27 million people in 2019 and associated with 5 million deaths. And this is actually from, this information is from the CDC's antimicrobial resistance threats report that just came out based on 2019 data. And in that report as well, every 4 hours, the CDC's AR lab network detects a resistant germ that requires a public health investigation. And many investigations have unusual resistance requiring a public health containment response by facilities. Sorry. There we go. However, infection prevention does work. So they show that 18% of deaths have lowered from strategies of infection prevention overall and 28% in hospitals. They've also found decreases for multi-drug resistant organisms, such as the is that showing? Maybe down here, but not up here. Okay. Well, the 33% is Carbapenem-Resistant producing Acinetobacter and 25% of drug-resistant Candida species. However, despite the infection prevention gains that we have seen in those statistics, we do still have a 2.8 million plus infections each year and 35,000 plus deaths each year. Well, what about Nevada? I read the news today. Oh boy, have you seen how Candida auris has been shown in countless news articles hitting local and national news? Multi-drug resistant fungus spreading in our hospitals. Health officials ask doctors to stay on high alert as it spreads. Potentially deadly Candida auris spreading quickly. CDC warns of alarming rise. Nevada, California leading the nation with the most superbug infections. Nevada has the highest case counts in the nation. And it just continues and continues. Superbug. Even Congresswoman in the news about C. auris. It's just really popped up. About Candida, yeast infections cause 3.6 million visits per year and $3 billion in direct medical costs. Candida auris, however, behaves differently than other Candida species as far as source goes, transmission, and resistance. C. auris is easily misidentified in laboratories, and the clinical decision-making is vastly different. 5 to 10% of those who are colonized with Candida auris or C. auris develop bloodstream infections, and 40% of those will die within 30 days. And that may actually be higher based on some other sources that I've seen could be a high mortality rate of even above 70%. C. auris is one of the most resistant species of Candida with only 3 classes of antifungals available. So 80 to 90% of isolates that are tested are already resistant to fluconazole, 2% to azoles. So fluconazole is an example of that. 2% and increasing is already resistant to echinocandins. 25% of isolates are already resistant to amphotericin B. C. auris is the fastest pathogen to reach 100 cases in the US. And it just increases. So it actually increased 318% in 2018. In clinical cases, it spread at alarming rates between the year 2020 and 2021. And in red here, you can see Nevada's contribution to those numbers. And the screening cases, also, we see they tripled from 2020 to 2021. We also found that resistance tripled to echinocandins in the year 2021. And echinocandins are the most recommended antifungal for treatment. So this is very concerning. I did want to show we have a variety of resources available in Nevada on C. auris. This is on our website, the Healthcare Associated Infections website. And here we have the C. auris training, which is actually a training provided by the CDC, the regional AR lab, and Camisha, our local HAI team. This is a great training they provided last year, providing really targeted information for Nevada and really helpful information for facilities as well. So I'm going to reference this quite a bit during my presentation, and I highly recommend going through this training. From that training, we do see that the cases at that time were 300 in the state of Nevada. There were a total of 22 facilities involved. They found unique factors such as surges in acute care hospitals, increase in clinical cases versus colonized cases, and that was a bit disproportionate, a little unique in Nevada's situation, and also pediatric cases, which are quite rare. Be sure that your facility receives and reviews our memorandums that we send out, as well as our technical bulletins. And we send out these as situation reports with the most updated information on C. auris and current recommendations. So here we actually stopped reporting deaths. That's something that more Camisha and the HAI epidemiologists can describe more on that. But we did see a huge increase in cases. They shared this graph here that shows a bit of an inconsistent detection. So this may be a surge here from either major transmission or major testing events. So as a comparison from last year's presentation to the memorandum that we just released, there were 300 cases as of June last year, and now 1,932 total cases. There were 22 facilities, and now there are 40. We did see the rare pediatric cases that they discussed last year. And now we actually have even more rare cases found in the neonatal ICUs. What are the risks of Candida auris? From the 2019 AR threats report that was just released by the CDC, they do provide some of the challenges that we're seeing, those common challenges in healthcare facilities that are presenting a higher risk for our patients. So including the introduction of emerging threats from outside the US, the spread of germs in non-hospital settings, such as long-term care facilities, the spread through healthcare environments, such as bed rails, devices, incomplete adoption of containment strategies, inconsistent implementation of CDC recommendations, such as isolation precautions, and continued vigilance against serious threats like nightmare bacteria, but in this case, our superbug, the auris. These are all items that the CDC have found that are additional risks to our patients. We also have to consider transmission by behavior. So looking on the left side, this is an example of how hands can become contaminated and should be cleaned in a variety of scenarios, such as before eating, after blowing your nose, coughing, sneezing, after using the restroom, touching doorknobs, contaminated surfaces, and before touching your eyes, nose, and mouth, which we do all the time, and before and after changing bandages. So studies show that some providers practice hand hygiene less than half of the times that they should. And studies show that's approximately 100 times per 12-hour shift. C. auris can colonize many areas of the body, including the skin. So it can grow and spread to portals of entry, which are ways that pathogens can enter and infect the body. So think of how some of these invasive equipment can increase the risks of infection. So even urinary catheters, which if there becomes an infection, can cause sepsis, which is actually quite serious. So this is why these types of procedures require staff competency with aseptic techniques and using sterile materials. Reservoirs are locations that pathogens can live and be transmitted from. So these reservoirs can be from our own body, such as the blood, respiratory droplets, skin, and the gut as well. And at times, patients can infect themselves from their own reservoirs and their environment. C. auris can live on surfaces for months. C. auris can be carried on healthy skin of staff or on their clothing and transferred through contact. Water also is not sterile, so and can contain resistant organisms. And supplies that should be sterile, let's say wound care supplies, should never be placed on sink counters or within a splash zone of the sink. And just a little FYI, looking through the news articles, I did find one that the Southern Nevada Health District has found C. auris genetic material in untreated wastewater. So, we're not sure how that can affect the future, but I just thought that was an interesting article. Medical devices, including shared equipment, vital scopes, radiology equipment, indwelling devices, these can all become reservoirs if they're not aseptically installed and maintained, or if they remain in place for an extended period of time. High-touch surfaces, such as doorknobs, can become reservoirs. And here, they're giving an example of dust. So they've got a ladder here to demonstrate if anyone's doing any maintenance on any ceiling tiles, that can disturb dust. So that's something to consider as well, as dust can carry pathogens. So imagine that you have cohorted roommates. Say patient A on the left has C. auris, which contaminates a provider or a vitals machine or other shared equipment. C. auris can be carried to patient B on the right and could even be transferred to portals of entry, which may directly lead to an infection, causing a critical transmission. And critical transmissions should be immediately corrected and contained because it compromises the patient's safety. So patients rely on infection prevention behaviors for their safety, and gaps in essential behaviors can cause these critical transmissions and compromise the patient. And with that illustration, think of how just even being in an overnight stay at a healthcare facility with high C. auris burden, such as Clark County, or being in the same room, ward, or unit as another patient who's colonized can be a huge risk. So when you think about just staying in these facilities, or if it's within any of these facilities, that's already going to be putting our patients at risk. Who are your high risk populations, right? So those who have additional portals of entry, such as any indwelling medical devices, ventilators, trachs, urinary catheters, lines, those who have wounds or post-surgical sites or any other infections, those who have a history of heavy antimicrobial use, immunocompromised, and those who have a history of antimicrobial resistance. The reason why that's important is that having any disruption to a healthy microbiome flora, such as antimicrobial use or a history of resistance, it can give C. auris the opportunity to be a dominant colonizer, and they can grow and spread more easily if they are dominating the skin or the body. So that's why they're more at risk. And those who have a healthy flora, even if they are exposed, they may not end up colonized because of that healthy flora that prevents C. auris from becoming dominant and growing. The CDC in the AR threats report has also provided strategies that are proven to work, such as preventing device and procedure-related infections, such as catheters and lines, stopping the spread of resistant germs within and between facilities, containing threats through early detection and aggressive response, tracking and approving appropriate antibiotic use or antimicrobial use, infection prevention and control in non-hospital settings, such as long-term care facilities. So all of these are items that should be part of an infection prevention and control effort. There was a recent press conference by the CDC that states that C. auris case counts have increased for many reasons, including poor infection prevention and control practices in facilities. And the timing suggests that C. auris may have worsened due to the COVID-19 pandemic. So has the COVID-19 pandemic introduced new risks unique to your organization and your network and your facility? Have there been changes in leadership or ownership, economical strain, retired staff, turnover and shortages, post-pandemic fatigued and burdened staff, and overwhelming new regulations? So how will your facility mitigate the risks of C. auris? and hopefully through an infection prevention and control plan. In the same press conference, the CDC, well, an epidemiologist, Megan Lyman, who has actually worked extensively with Nevada in our response, this is a quote from her saying the rapid rise in geographic spread of C. auris cases is concerning and emphasizes the need for continued surveillance, expanded lab capacity, quicker diagnostics, and adherence to infection prevention and control. And these are all elements, again, that should be a part of your infection prevention plan. So in your plan, these are recommendations that your plan should be unique to your facility, unique to your location. If you have corporate plans, some corporate leaders are actually out of the state, so they may not be following local epidemiology and the threat of C. auris and making sure that's included in the plan. So include surveillance and testing to detect transmission and to control and contain any sort of transmission of C. auris. Have a strong antibiotic stewardship program. It's recommended to have a primary and a secondary equally trained and capable infection preventionist. Have an emergency preparedness plan that looks into the emerging threat of C. auris, and especially for those in the north and in some of these rural facilities. Be sure that you are prepared, that's already a part of your plan because of the epidemiology here. And include an outbreak response. So that's already in your plan, and your staff are already trained and already prepared in case there's an outbreak. Select standards of care from nationally recognized organizations such as the CDC and prevent the spread of infections to other facilities. There are resources. I'm going to show a few resources today, and they're just only a few resources of the many that we have available. And many resources will guide facilities from beginning to end. They help with leadership involvement. They'll check your policies, check your procedures, check your practices, and they even provide observation and audit tools. They provide evidence-based recommendations for the gaps that you find through these resources, and they provide updated modules with some of the newest information. Prevention first, right? So here we have the iceberg effect. Now, why are infections considered more visible? Because those are the ones that need immediate attention for your. So those are the ones that are more detected. However, infections are really only a fraction of the colonized individuals that exist in your facility. Remember that colonization is a continuum status. So studies do show that there's inconsistent lab results. If you were to test and they come up positive, test them later, they may come up negative and then later come up positive again. So the CDC has shown there's inconsistency there. So it does have to be considered a continuum as if they're colonized indefinitely. And that's also important because colonization is a precursor to infection. Those patients are at a much higher risk for infection. As we know, as if it enters the bloodstream, the mortality rate can be quite high. Those who are colonized also can still transmit C. auris to other people into the environment and as well as equipment. Be sure that you're tracking data, so establish a baseline of your C. auris data. And establishing a baseline can help you to detect any new transmission that's happening, whether that transmission is internally, and it can also help you to detect any transmission that's coming into your facility. Be on top of your lab reporting and your isolate submission. Speciate for all Candida species. And I emphasize this again and again, because even my experience working in the lab and trying to speciate Candida, it's not easy. You really have to have the top of the line equipment. And unfortunately, where we are right now, there's very limited testing ability for C. auris. There's not a lot of FDA approved diagnostics. So make sure that your lab that you're using actually has that capability, or they're forwarding those isolates to our public health lab that can help out with that. An antibiotic stewardship program is preventative. Sometimes you may think, oh, this is just to help the patients who have current infections that may have current resistance, but actually this is preventative. As I mentioned before, maintaining a healthy flora is going to be a prevention method for your patients. One of the resources I wanted to point out, again, sorry for this distortion here. This is a guide for MDRO prevention, and I recommend using this CDC resource, implementing this into your plan. And I wanted to go over strategy 3 within that plan, which is detect colonized individuals. They provide a table along with other evidence-based information that can help your facility to know your position. You know, what should you be doing to detect individuals? And first, what they'll do is they'll have you define your position in a risk stratification. So what category are you? Are you an influential facility? Are you a highly connected facility? And in terms of your network of patient sharing, or are you in the other category? And with that information, they kind of give you recommendations for whether or not you should be performing prevention-driven point prevalence surveys. Now, that's when your facility tests a high-risk unit, or whether or not you're testing the whole census of your facility. That's going to depend on your facility type. So they give great recommendations based on your facility's position in your network. And these point prevalence surveys, they also give recommendations about doing predetermined routine point prevalence surveys, because again, that's where the prevention comes in. If you do it once and you get a baseline for where your facility's at, if you're not doing another one, then you're missing any opportunity for detecting transmission. So that's why they may have your facility recommend doing routine checkups to see if there's any transmission that needs intervention. The resource also assists facilities in determining your admission screen. So based on your position in your network, is that something that you really should be doing to prevent any transmission coming into your facility? So this is a really great resource that I recommend. I want to re-emphasize from the CDC's training last year. This is a slide from their training. We are all connected. Healthcare facilities exist in intricate networks of patient sharing. What one facility does or does not do can affect the whole region. And limiting the spread of MDROs is everyone's responsibility. And I actually like this. I know it's a bit small here, but we have our public health department right in the center of it. And that's where, you know, us, Kamisha's team, our HAI epidemiologists who are constantly bugging you about reporting and your case counts and the situation, they're central to that. So we're here to really help you to understand your position as far as outbreaks go. Similar to that guide I showed you earlier, this is basically the same thing, but on the containment and response side. The other is prevention. This is what do you do if your point prevalence survey comes up with a ton of positives? how are you going to contain that and how do you respond to that? So I would recommend looking into that as well. Remember that prevention works, and the CDC does have these strategies that are proven to work. So back to this case that we discussed earlier, let's say we have two patients that are cohorted, one has C. auris or they're in the same unit. So when you know the risks, the reservoirs, the portals, you can apply evidence-based recommendations to mitigate these risks. So if the IPC plan, Infection Prevention and Control Plan, is followed and they have the risk components that are mitigated with evidence-based practices, you can prevent transmission. So for example, proper PPE use, proper hand hygiene, and proper cleaning and disinfection of reusable medical equipment and shared medical equipment with the EPA approved disinfectant and a proper contact time can disinfect the equipment and prevent transmission to patient B. And for your information, C. auris has its own EPA approved list, which is list P. And if you do not have disinfectants, if your environmental services staff do not have anything on that list, whatever's working for C. diff, which is list K, can also kill Candida auris. Never underestimate the power of hand hygiene, which can prevent 1 in 3 diarrhea-related sicknesses and 1 in 5 respiratory. Alcohol-based hand rub is more effective at killing MDROs, and it does work against C. auris. It's the preferred method in most clinical situations, and it's much more gentle on your staff's skin and hands. So if you remember, if they're doing hand hygiene 100 times per shift, if it was soap and water, their skin would become quite raw, and that can cause dermatitis. So the CDC actually has recommendations for facilities to provide approved lotions for your facility and for like clinical lotions that are safe for patients. And that would eliminate dermatitis and some of the obstacles. You know, if you already have dermatitis, you're not going to want to do hand hygiene. So the CDC does have some of those recommendations as well. And remember, there are some situations where you have to use soap and water, such as with Clostridioides difficile, norovirus, and if they're visibly soiled, come in contact with bodily fluids, things like that. Your plan should have an interfacility transfer form that we have actually improved. We've been editing this quite a bit with the new Candida auris counts. So we actually have included some illustrations of the precautions in this form. And we've included Candida auris here. We've also added test pending under the status. So this should trigger facilities to make sure that they're using the right precautions. If there are any labs testing, they should be on empiric precautions. So use this form when transferring either to or from your facility. And make sure that when you're discharging that you're sharing the culture reports and the antimicrobial susceptibility reports so that they can include that with their antibiotic stewardship. One thing I wanted to note is that even though it just shows airborne, contact, droplet, and standard, we do want to consider empiric precautions. And we do want to consider enhanced barrier precautions, which is only used in long-term care facilities. So again, we have the contact, the droplet, the airborne. But enhanced barrier precautions is kind of newer for our long-term care facilities. And that's because more than 50% of nursing home residents carry a multi-drug resistant organism. So think about that with your census. And these precautions should be used on residents with indwelling medical devices, such as central lines, catheters, feeding tubes, trachs, vents, those who have wounds. And it's also going to be used for those who are colonized with an MDRO. So it actually does both purposes. It's protecting the vulnerable while also containing those who are colonized. Now, these precautions are a bit different because it depends on the activities that you're performing with the resident. They're not confined to their room like they would be if they're on contact precautions. There's more flexibility since they're living there long term. So really, when they're colonized, they're really only, at a smaller risk than if they're infected. So we're trying to consider all of these factors as far as risks go. So those who need to be on enhanced barrier precautions, you're really going to be using gloves and gown for just the high contact activities. Unfortunately, you will find that that's going to be a lot of activities that you'll be doing with them. But as far as just going into the room and leaving the room, doing a few things here and there, you don't have to gown up and glove every single time. It's really just for the high contact activities such as dressing, bathing, changing linens. MDRO staff training and competency should be performed upon hire prior to providing care or specific procedures annually, and with the introduction of new threats like C. auris, new protocols, new equipment, or new policies. Competency-based training is measurable or observable knowledge, skills, and behaviors that demonstrate job performance. They're role-specific and should be based on the latest evidence-based standards. So include characteristics of C. auris, fundamentals of transmission, and IPC principles and strategies in your training. Using a feedback loop that is a flexible, continuous system with audits and feedback can reinforce staff improvement for your organization. And it all starts with the basic training. The 4 components of competency-based training are assessing education needs, design, delivery, and assessing the competence of your staff. So first, how do you determine the priorities for your training? Are they mainly based on regulatory agencies such as OSHA, CMS, Joint Commission? Are they based on state requirements or recommendations? Or do you also include your own facility's data from your audits? And maybe if you're using the CDC's TAP program or from your NHSN data, the National Healthcare Safety Network data that you may need to be reporting. Optimize your training to the needs of your learners. It's suggested that 80% will be retained by what is heard, seen, and done in your training. There is a time and a place for e-learning, simulation skill labs, lectures, or bedside training, but be sure that you're incorporating hands-on training that they're performing, the learner's performing, such as doing like reverse teaching methods so that they're actually doing it as you're training with them to optimize that retention of information. Create a suitable learning environment. So one that's going to be active with discussion groups, case studies, and role playing. And assess their competence. So do they know the material? Do they know how to apply the knowledge that they've gained, such as in critical thinking situations? Can they show you through demonstration? And can they perform independently without supervision? I want to make a note here. Equip all of your staff with knowledge and information and training, because in the cases that we saw that went to the pediatric cases in the ICU, the PICU, it's possible that you may not think that low-risk units need to have the same training as high-risk units. However, we did find transmission. So remember that even though it may not be likely that they'll have infections or a prevalence, still make sure that they have that training and that you're equipping all of your staff that may come in to see auris cases. Equip administrative staff that may look at or use this form in any sense. So which staff would be filling out this form? Which staff would be requesting this form, uploading it to an EMR, reading this form? Do they have MDRO training? You may not think that, case coordinators or admissions coordinators might need to know about precautions or how to look at records and to know if this is filled out accurately. Are they notifying of any pending lab results that would indicate empiric precautions or any situations, any history where long-term care facilities would need enhanced barrier precautions? And another example, the CDC provides a graphic novel that's interactive for environmental services staff. So this is Sophia, who is a trainer for a new EVS worker. And she says, our job is infection prevention and control, or IPC. Our EVS team is the first line of defense against germs in the hospital, especially those that are resistant to antibiotics. Poor environmental cleaning and disinfection can lead to spread or healthcare-associated infections. And they even demonstrate, look at a room. What do you think needs to be cleaned? They'll point out the things that need to be cleaned that are visible, such as spills or the trash can or dust. But they also demonstrate what needs to be cleaned that is unseen, such as germs or resistant bacteria or C. auris, and some of those surfaces, like high-touch surfaces and areas that they should be educated on. In another scenario, in this example, this is Bill's room. He told me he has the flu. We need to make sure that the germs don't spread. Something seems off here. Yes, that's right. There should be a droplet precaution sign outside Bill's door to warn about germs that are spread by tiny droplets. So again, just equipping your staff with infection prevention and control skills can benefit everyone in the facility. And remember that that other staff that are not clinical, they can, with proper training, they can perform audits, just secret audits and observations, and collecting that data for your facility and for your organization, including maintenance staff. So earlier, if you include maintenance staff with infection control training, they can maybe say, hey, we're going to be working on the ceiling over here. Do you think it's a good idea to close the patient's doors during that project, or just in case there's going to be some dust, or and they can also perform observations, silent observations, and just be collecting data for your facility. Equip your staff with as many resources as possible. This is a pocket guide that the CDC created that you can fold up and your staff can carry in their pocket about enhanced barrier precautions, because it's a little tricky because it's based on scenarios. So it actually has the information that they need in a moment of confusion, that they can just pull out the card. It has the types of residents, the scenarios, and the steps on what to do. How to detect gaps in your IPC practices. Build and use data. So epidemiologists, we use our data to determine any sort of gaps in infection prevention and control, detect transmission, things like that. So just as an example, with the illustration comparing last year's data to this year's data, we can look at the case counts, and we know that there's still transmission happening. We see a huge, enormous increase in the past year. Not only did we see the pediatric cases last year, but now we see that there's been transmission to the NICU as well. So we know there are gaps in infection prevention and control of cleaning and disinfecting of reusable medical equipment, or rather it's suspected because we've seen it before. And it's such a similar situation. So our epidemiologists are able to suspect certain gaps, and if you target in on that information in those gaps, you can prevent it quite easily when you really identify that. We also see that it has spread to other facilities as well, whether these are facilities that have it, or rather I like to say participating facilities in testing. So with the data, we see that, for example, our skilled nursing facilities, last year we had 8. Now we have 9 or 5 ventilator SNFs. So basically in Southern Nevada, we know there's almost 40. I don't know the exact number. So we see that that number hasn't quite changed. And based on the data that we have here, it's possible that there just are facilities that are not participating. And other data that can help us, this was from the CDC, where they were able to identify gaps in testing because Nevada was able to identify 83 cases in just over half a year. When compared to the other states, they got to that number of cases in 2 to 5 years. I believe that is, yes, 2 to 5 years. So that's an indication that there may have been an extended period of time without testing events. And when a testing event did occur, it uncovered a high prevalence or a high ratio or proportion of cases. Other data that can be helpful is looking at the differences between your clinical cases, your infections, versus your screening case count or your colonized count. And that is an indication that it suggests your facility may have undetected colonized individuals. If that number is a bit off, you want to see much more screening than you do clinical. And this is Nevada. This is an example of Nevada here, where we had, you can see the difference, where we had more clinical than screening at one point. And another great example, and I love this example, this gets into a much deeper level here. We actually had a great example that the CDC provided us, where one unit was being monitored for C. auris and also the resistant genes that we find on resistant organisms. And as you can see, the purple is C. auris. So they were able to trace the genes or the C. auris to different areas of the unit. And if you actually get such great accurate data like that, you can trace the transmission to certain equipment, people, staff, and even if you have the genetic data that I've heard of, finding epi-links to mobile residents who have a resistant gene. And it's interesting when you can find that the resident likes to visit certain people in certain rooms or places in the facility. So it is interesting if you are collecting that data, you can target where your transmission is, pretty well if you're on top of that. So I thought this was a really good example. The CDC does have this great program, TAP, Target, Assess, Prevent, and it's based on data. So the CDC has this program to assist facilities with using their NHSN data and helping them to track their infections, and some of the most common ones, such as bloodstream infections, urinary. So using this program, there have been countless testimonials from facilities of its success in preventing infections. And we know these infections can be caused by C. auris. And we know if we have a bloodstream infection, the mortality rate can be quite high. So I would recommend looking into this program. Use facility data from these secret observations as well as your one-on-one performance observations that you have with individuals, and use that collective data to determine your organization's compliance with infection control. And this looks at the organization as a whole, right? So it's not just feedback to individual staff members, but it helps your facility understand the systematic gaps that may exist in your policies or in your training. And that should feed back into your training. Make any training adjustments you need to in the gaps and areas you need to improve. And then again, you can also adjust your audits to really target in on those areas you need to improve. If you've ever had a visit from myself, Jennifer Connolly, Fatia, Terry Lynn, John, so we actually use a lot of questions in our assessments during our on-site visits to your facilities from the CDC Infection Control Assessment and Response Program. So these are tools that you should use for your facilities. We basically are here to just get jump started and ask those questions that you may not have considered before, but you can do this yourself. And it starts you out with your facility's demographics. Go into, are you a ventilator SNF, or are you just, a non-ventilator SNF? They'll go into some of those demographic details and where your position is as far as infection control goes. It also provides 11 modules that they're constantly improving and updating. For example, the water exposure is kind of new. And I recommend going through these modules. These are some of the targeted areas that should be a part of your plan that you're looking into. It also provides observation auditing forms. And with all of these resources, they provide evidence-based recommendations for any gaps that you're finding from your assessment. So really, you can use it at your own pace to, use it to your advantage. And if you need any help, we've been doing this for you guys and making reports for you, but I cannot recommend these resources enough. So during our on-site visits, these are some of the common gaps that I've been finding, but really I'm just looking at Southern Nevada. Those are just the facilities that I visit. But during my visits, I see that facilities are more reactive than preventative against C. auris. It's still kind of new, so things haven't quite been implemented, or training hasn't quite occurred for all affected staff, and data has not been collected. So a lot of facilities don't have a baseline, and I am happy to help with this as well, with collecting data. That can be new for a lot of people. If there's a lot of turnover in your facility, turnover with your infection preventionists or leadership, that can also be a struggle in trying to gather data as well. So yes, again, the prevention is not just, you know, it's not just supposed to be for the high risk areas you think, but all affected areas of the facility. And we're finding that there's limited reports of any breaches or gaps or exposures, when really those should be triggering an outbreak response. And really that should be feedback going into their systems and programs and discussed in their quality meetings. We also find interfacility miscommunication of patient infectious disease status, such as the misinformation people have that if you've got multiple negative results after they've had an infection, they may think that they're clear, but we know that's not the case. They can still be colonized. Training, audits, and feedback are brief and not reinforced, and staff are not adequately equipped with information, resources, and support, such as hand hygiene products, alcohol-based hand rub. You know, I love to see those dispensers everywhere, you know, right next to the patient care area. I do not like to see any disruptions of the workflow for our staff, you know, that they have to travel far or remove their PPE to perform hand hygiene and then don and go back. I'd like to see a nice workflow for our staff so that they can be as efficient and not be as disturbed as possible. So that concludes my presentation. You need help, we're here for you. The HAI epidemiology team, they're excellent, and we collaborate with the CDC, and Comagin is a great partnership that we have. So I'd just like to open that up for questions, and I'll leave, this is our contact information for our HCQC team, and open up for questions. Hi, Sean. Yes. Yes. That's a great question. And if you didn't hear that in the north, for enhanced barrier precautions, so the resident does not have to be contained to their room, but should they be wearing any PPE, any other sort of protection? Especially as I mentioned that there was a study that they could epilink a mobile resident spreading resistant genes to other areas in the facility. And really the CDC recommends that you are training your residents, educating your residents and training your staff to educate them on hand hygiene and cleaning and disinfection. Because they really should be performing hand hygiene, coming in contact with the environment, and also cleaning and disinfecting. Say they use the therapy room. So if they're doing any physical therapy, that's fine. They don't have to be confined. They can still go and do their physical therapy, but make sure you're using an EPA approved List P or List K disinfectant. And that the resident as well as staff, they understand who is under those precautions and for what. It's a little tricky because again, enhanced barrier precautions doesn't just mean you have to disinfect everyone who's on that, only those that are colonized. So we really only need to be careful about those who are colonized under enhanced barrier precautions. Thank you. Any other questions? Yes. Oh, thank you.
Testing. My name is Vivian. I'm the staff educator in the IP at Spanish Hills. I just want to clarify when you say colonization with the CRS, I just want to confirm that we do put them into enhanced barrier whether they have any devices, right?
Correct.
Yes, okay.
Yes,
Just wanna make
thank
sure.
you, Vivian. Yes, because, and I know it's tricky, trying to really understand the concept that enhanced barrier precautions is just an enhanced barrier. If you think of some sort of a barrier for those that are vulnerable and those that are colonized with an MBRO. So yes, and the behaviors you're going to be doing, again, if they're mobile, it's going to be a little different whether they're colonized or if they're just vulnerable. Because if they're colonized, you're going to educate them on hand hygiene and train your staff on the cleaning and disinfection when they're out in community areas. Any other questions?
Thank you. I'm Lisa. I'm from College Park. I'm the Director of Education.
Hi.
So to follow up on that then, cohorting.
Yes.
I've got a CRS colonized resident who can't get out of bed, who's trached, vented, possibly they're colonized. I have a second resident who is trached and vented, doesn't have CRS. We can maintain the 3 feet between them. Can they cohort or can they not cohort?
So this is a great question. It's actually in one of the modules, the CDC modules that we use in our visits. And we want you to think about the risks and consider those decisions along the way. So cohorting. Is there any possible way that the vulnerable can be separated from the colonized? And if not, what are you going to do to mitigate that? Are there any additional resources you need to put in that room, and any other sort of ways of dividing for your staff, so that they know this one is colonized, this one is not? And those are going to be things that you're going to want to discuss with your interdisciplinary team. But it's not recommended to put to cohort a vulnerable with a colonized, if possible, really, because they are so vulnerable that accepts. Exactly. Yes. What do we have left? Exactly. Right, right. I know it's so tricky, and that's going to be a discussion with a lot of people too. I've seen maintenance get involved in these discussions, and it's really quite helpful. And we can come and visit your facility, look at the layout, have discussions, brainstorm with you, and really that's something you'll want to brainstorm with your team. What can we possibly do? And let's think of all the factors involved here. Do we have a good compliance of hand hygiene and cleaning and disinfecting? Or do we have disinfecting solutions or wipes that are easily available for shared equipment, so that we know that staff, if they need to use an equipment from one to the other, they can quickly disinfect that? So if you are having gaps with hand hygiene or cleaning and disinfection, you may want to consider your census or things like that. And I know College Park is one of the few that will do their best. So that's great. Thanks for your efforts on that. But it is tricky, and we can help you with any of those questions and do an assessment for you. Keep it contained. Exactly. So you may need to think about your census and if introducing those risks are worth it, or that those are discussions that you guys will have to have.
We have a question on the chat if there was any update on guidance for decolonization of CRS patients.
Thank you. Yes, that's a question that's been coming up. And we did just talk to the CDC about this because we had a question, and they confirmed that still studies are showing that there are really no solid methods. So it's not recommended to try to do any decolonization with CHG, things like that. That's just not something that's available at this time.
And then we'll take 2 more questions for the sake of time. Chrissy, you had some
Oh.
questions in the north?
Yes, can you hear us?
Sure. Oh, do we need the mic?
There were some questions in the
Or-
north, trying to get their questions answered. We can't hear you all if you are,
Hey, Kamisha, can you hear me?
Oh. Yeah, I can hear you now.
Oh,
Okay. There's no questions.
I don't play that. Hold on, I'm running to them. It's good, you can go on the side.
Hi, hopefully you can hear me. I guess. Okay, so, in terms of doing point prevalence surveys, are you aware of having any supply issues at the state lab to actually be able to do CRS testing? Because we've had, when our facility, when we transfer to California, we have to do CRS testing. We've had one pending for multiple weeks because of some issue that we're not totally clear on about, reagents or something at the state lab. So what is a plan for like doing more solidation as like prevalence testing if there's not good testing resources available?
I apologize. It was a bit difficult to hear. Correct me if I'm wrong. The question is, have there been any issues with supplies of testing, capacity for testing, and access to our state lab testing? If there are any surges for point prevalence surveys, is that the basic question, or am I missing any components?
Faye, this is Jen. Yeah, that's the overall question. They have a test pending. California is requiring screening to be done prior to transfer. And they have run into issues where screening is delayed, which then delays the transfer of the patient. So they're just curious on what our backups are, or what going forward with the state lab, what that looks like for capabilities for testing and screening.
Okay, thank you, Jen. So I actually went into this with Kamisha. We kind of looked into this because we were encouraging more point prevalence surveys, thinking of testing other large populations. And from our understanding, the turnaround time is still quite good at this time with our state public health lab. So as of now, they're doing great with capacity. And we have also had conversations with the CDC's Antimicrobial Resistance Laboratory Network, which is located in Washington. And we've had that conversation that in the case of any surges, the state lab knows to forward that on, or so it sounds like they have a really good network and a really good collaboration with the regional lab as well, and that the turnaround time so far has not been much of an issue. So that's what I've been understanding. I'm sure if Kamisha has.
Since we're muffled.
Yeah, so overall, the turnaround time, I believe, is supposed to be 24 to 48 hours. It depends on when they receive the specimen. We've had some issues with that, with people saying it wasn't that 24-hour turnaround because they came in on a Friday. So if they come in like on a Friday, then they're not going to get to it until Monday. We have had some facilities having issues receiving the results in a timely manner. So if you run into those issues, please email your HAI contact, or you can email myself. I receive a weekly email from the lab, and so a lot of times I'll have those results on my email. So, I mean, everything's not perfect. We do run into some issues, but for the most part, I believe everybody are getting those results in a timely manner.
Thank you.
We did want to go over this slide. I have Chrissy on the other end. She's up north, but she's the one who creates this epi curve. So Chrissy, if you could explain this slide, please. Thank you.
Can you hear me? Kamisha?
Yes, I can hear you.
Okay, perfect. So we create this every single week. And just for clarity's sake, I wanted to go back over this. This is demonstrating that, 2023 has been fairly consistent with cases. We see that huge drop in September. That drop is only because it was literally within the first few days of September. So our case counts are consistently this high. This was not an anomaly month. If you looked at September now, it's right back up where the rest of them are at. So I just wanted to be clear here that this blue box is just showing you that it's incomplete reporting for those periods that you're looking at. Is that good, Kamisha?
Yes, thank you.
Okay.
We had one more question in the back, in the red room coat shirt.
Oh, thank you. If there had been an updated time frame from CDC as to exposure to colonization and colonization to infection.
I have not seen any updates. Through my research, it's still inconsistent. It's really hard to give an accurate amount of time for incubation periods, things like that, right? That's the question for when we, if they're exposed, say day 0, when should we be testing them to see if they ended up contracting? It's very difficult to tell at this time.
Okay. Oh, one last question, then we'll move on to Jen's presentation.
Julie Miller, UNLV School of Public Health. Hi, Faye. Sorry, we worked together at the COVID response up in Utah.
Yes, we were in the trenches during the pandemic.
So quick question on the point prevalence surveys. I'm just curious, is there any suggestion to test staff members in point prevalence surveys, or are we just testing patients, residents?
Just patients and residents, yes. And actually, the CDC did do a study. There's a study that when they did test staff, it's very common that they're not contracting it at all because they've got a healthy flora. So it's really not a good representation of whether or not they're transmitting. So yeah, thanks for the question. Vivian, I saw you had one, but maybe we can discuss later. Okay, great. Thank you all so much. Appreciate it.
Thank you, Faye.
Hey, Kamisha, just a quick question for you. Do we need to record up here or are you recording down there?
I'm recording down here. Do you want to do your own slides? Because I would have to
Nope.
move them
I got
along
my own
for you, or you
Yep,
can
we're
present
good.
from your end.
Yep.
I didn't hear your response.
Yes, I will do my own slides.
Okay.
Can they see our stuff?
Christy wants to know if you can see our stuff. See my slides. Probably not online. It is showing up online? Okay.
Okay, good.
And Misha, just to confirm, you can see my slides, right?
Doesn't it?
Yes, I can see your slides.
Cool, thank you. Okay, so I have to make up some time now, so that we can get you guys to lunch one time. So I'm gonna go through this. I do want to give a preface here that for some of you in the building, hospitals, a lot of this is gonna be a little rudimentary, but we want to make sure that we're covering all licensed healthcare entities in the state of Nevada. So that includes group homes, assisted livings, all of that kind of concept. So a lot of what I'm going to go over is truly how to create your plan and what we're looking for. There's still some good little fun things in there, but from a hospital level, it might be a little low level. So we'll just go through them. Maybe. Maybe not. Oh, please. Oh, please. Maybe because you're not in slideshow. We're having some technical difficulties, so please hold.
It's a big deal for you.
Yep. Okay. Like I said, okay, we're gonna do this ourselves. I'm not sure if it's big enough though. Do you know how to use this stuff, anybody?
Can you guys see it like normally on yours, or does it look like presenter view? It shows up. No, it shows up normally. We're
I think
getting,
it's just
our screen.
Okay, okay, fair enough. Okay, so let's go. Let's do this. Go ahead to the next slide. You're gonna go a couple slides.
Maybe. Okay.
Sure, we'll start there. Chicken infection. So go ahead, next slide. This is really small. So chicken infection, obviously is in the process in which a pathogen spreads from one host to the next. The process has 6 steps. Each step of the chain is required to effectively transmit a disease. Breaking one of the links can slow or stop the spread. Go ahead to the next slide. So pathogens are microorganisms that cause the disease. Different examples are bacteria, viruses, fungi, parasites. As we just heard, fungal is, the rage in Nevada. Keep going. I know, I'm gonna go through this. Our reservoir, a reservoir is a place in the environment where the pathogen lives, replicates, and thrives. Areas where a pathogen may live, humans, obviously symptomatic infection or asymptomatic carriers. Good example, typhoid Mary, gotta love her. Animals or insects, Lyme disease is an example, or rabies, which, by the way, totally random side note, there's a lot of people right now because of the antibiotic resistance or vaccine resistance. A lot of people are not vaccinating their animals against rabies right now. It's declined drastically. So, side note. The environment, soil, water, Legionella, my favorite topic. Go ahead. So portal exit refers to any route that the pathogen can leave the reservoir. So through the GI tract, which is vomiting, diarrhea, saliva, urogenital, sexual contact, respiratory, secretions from coughing, sneezing, or talking, and skin with open wounds. So direct contact is considered person to person. So skin to skin, like touching, again, open wound to open wound, kissing, sexual contact, contact with oral secretions, or contact with body. Droplet, which we've dealt a lot with in the past 3 years, droplet plus, shall we say. Transmission requires a pathogen to be transferred through the air in droplet and body secretions. So they are relatively large. They fall within 3 to 6 feet, which again goes back to keeping beds 3 to 6 feet away from each other when you're in a room to try to limit that exposure. The droplets will fall on nearby surfaces, tables, doorknobs, high-touch surfaces, and can remain viable for a decent amount of time, depending on what the droplet itself is. Some pathogens will live for a few minutes to hours, while others will survive for a few days. So strep throat can survive for up to 6 months on surfaces. Again, keep this in mind, that is in lab studies, right? Perfect environment, perfect everything. Influenza can survive 24 to 48 hours. So if you are noticing an increase in influenza in your facility, start doing high touch surface cleaning. That is super important. So droplet, I don't know if you can see my little guy here. He just sneezed a huge loogie out of his nose. So obviously we want to make sure that we are containing that, and we are sneezing and coughing into our elbows or into a tissue, and immediately performing hand hygiene following that. I would look like that little girl as well if I saw that happen. So go ahead and next. Airborne. Airborne transmission occurs when pathogens smaller than 5 microns in size remain suspended in the air long after the infected person has left the area. A host then enters the space where the pathogen is suspended and has then potentially become infected. So examples are measles. They can remain suspended for up to 18 hours after an individual coughs, sneezes, or talks. So I don't know, for those who were in the Reno area a couple of years ago before COVID, there was a measles case at UNR. And let me just tell you, they went everywhere under the sun through Washoe County. They went to the movie theater, to the bowling alley, to skiing outdoor, they were. So trying to track that down was going to be interesting. So I feel for Washoe County Health Department in that endeavor. And then tuberculosis can remain suspended for up to 6 hours. COVID was, at the beginning, obviously we still utilize N95 masks. It does fall between those sizes on microns from airborne to contact, which is why it is recommended that we still utilize N95 masks when caring for active COVID patients. Just kidding. Okay. Bloodborne. Some of these pathogens are transmitted directly through the blood. They require infected blood from the reservoir to be directly exposed to the blood of the susceptible host. So examples of these would be from needle sticks and blood entering mucous membranes or open wounds. So HIV, Hep B, Hep C. Those are some of those examples. Vectors. Somebody said it, or you guys were saying it earlier today. Vector, right? Our Despicable Me guy. Vector transmission utilizes insects to transport the pathogen. That insects such as fleas, ticks, mosquitoes. Mosquito West Nile. I know every so many years here in Washoe County, we have a pop-up of West Nile spots, particularly out in Spanish Springs lately, I've noticed. But that's a interesting one. I think with all the new building out there, they create little areas of pockets. Fleas, bubonic plague. Let's hope that doesn't come back. That might be our next lovely pandemic that we could deal with. Ticks, Lyme disease, and Lyme disease is getting a lot more coverage right now with a lot of celebrities claiming that they have Lyme disease. So it's getting a lot more preference. Portal of entry is the opposite of the portal of exit and is any route that a pathogen uses to enter the body or the host, the susceptible host. So inhalation, right? So breathing in all of those droplets that are in the air. Absorption via mucous membranes, such as the eyes. Recently we had, there's a big thing out right now, 27 different eye drops that are pulled from the shelf because of being non-sterile. And they do have staph auris, and it's multi-drug resistant. So which has been identified. We had one case here in Northern Nevada. We were lucky. They are well and good, but across the country, there have been many that have died and also blind from it. So be careful on eye drops. Check before you buy new eye drops if they're on that list. Ingestion via the gastrointestinal tract, or introduction via the insertion of medical devices. Obviously, Faye talked about making sure that sterile entries, you have aseptic technique, all of the above. Those are big deals. Okay, so our susceptible host. This is the last link in the infection. So how susceptible a host may be depends on many factors. So obviously age, young, old, is a huge importance. So the younger you are, if you are a preterm baby, you have higher risks, obviously, for scenarios. And the older you are, you have higher risk for contracting things. Your health status, if you're malnourished, dehydrated, or otherwise unhealthy, you are more at risk. As they also noted, if you have other multi-drug resistant organisms, you are at higher risk for contracting newer ones as well. Your medication usage, if you're immune suppressing drugs, if you're on that, you have a higher risk of containing or getting staph. Also, as well to that, if you are a big user of antibiotics, you will potentially become a higher risk for becoming a multi-drug resistant organism carrier yourself. General resistance factors, intact mucous membrane, skin. So, especially in healthcare, we talk a lot about turning patients, making sure that we don't get any bed sores, things like that. Those are all entrance points into having infections. Go ahead. So breaking the chain. So we need to control or eliminate the agent at the source by first identifying the pathogen to know how to protect other patients and treat the active ones appropriately. So this one, obviously, we need to be proactive at the bedside. It shouldn't just be the IP that's the one coming in saying, oh my gosh, this person has this. The people that are working bedside, CNAs, nurses, LPNs, even healthcare personnel. I will tell you, our EVS crews, they are sometimes the best identifiers because they don't want to bring anything home to their family. And so they will come to you and say, Mr. So-and-so in bed whatever B started randomly coughing today and I haven't seen him coughing for a while. That's a good one to go check on that person and identify if you should be increasing PPE practices for that particular patient. And then of course, hand hygiene consistency. That is the oldest first practice that they teach you in nursing school is hand hygiene. So, you know, as Faye said, and I'm going to repeat it, rates are below 50% currently in healthcare for hand hygiene compliance. So obviously PPE should be considered both symptom-based and pathogen-based. So there's your lovely guy and all his PPE. Examples would be a patient with an oozing wound, but no culture's done. That would be something that your bedside nurse or CNA should say, we should put them on contact precautions until we identify what's going on. That is an area of transmission. Patient with no MDRO colonization or infection. Obviously, that's important if we know that they have this, which goes back to Faye's discussion on interfacility transfer forms and having good communication with facilities that you're transferring to and from. So respirators, obviously, like we said, pandemic, we've seen a lot of the use of these. There is the link there for the OSHA guidelines and having a respiratory protection program in your facility and what that requires. In any workplace where respirators are necessary to protect the health of the employee or wherever respirators are required by the employer shall establish and implement, and you go back. Thank you. A written respiratory protection program with worksite specific procedures. And the program shall be updated necessary to reflect those changes. Fit testing must be done no longer than every year unless there's changes in the person's weight, dental, if they have facial surgery. If I had a nose job, I'd have to get re-fit tested.
The thing has in mind, but don't.
I see. So hand hygiene, obviously going back to that, the 5 steps of hand hygiene before touching a patient, before any procedure or personal care activities, after a procedure or any bodily fluid exposure, after touching a patient, after touching patient surroundings. Now, these are the 5 steps. However, there are also included steps if you're doing wound dressing changes or central line dressing changes that you have to implement hand hygiene in the middle of that process to make sure that you are not going from that dirty to clean and contaminating it. Increasing your host defenses. Vaccinations, number 1, right? We keep pushing this. I am getting my updated COVID vaccine and my flu shot tomorrow. So this weekend is going to be lovely for me. I get hit down every single time with vaccines, and some people don't. But vaccines are your number 1 protection option. For older populations at higher risk, along with vaccination, there is prophylactic drugs that is available, but needs to be handled through the physician. So your standard precautions used for all patient care. Now, again, this goes back to common sense thinking at the bedside. Standard precautions should be done in the moment, should be a review process. It's based on the in the moment risk assessment. And I know I say common sense, and I know it's not so common anymore. I would love if it were more common, but we really need to start getting bedside nurses to think about the patients they're caring for. Rather than it being so specific to just an outbreak, we want to make sure that they focus on every individual patient and the changes in their condition to then identify if there needs to be increased PPE usage. It not only protects them, but it protects the other staff in the building and the other patients as well. So transmission-based precautions are the second tier of basic infection control, and they're to be used in addition to standard precautions. So this is truly when we identify that they have something that they need to be on, either contact, droplet, airborne, if that's the case. And that standard precautions is that first level. So we really want to start educating staff to think on that tiered approach. And again, there's the CDC Gov information for isolation that goes over different timeframes on what should be isolated for. You can look specifically on influenza, on COVID, all of them are included on there. So identifying transmission-based precautions. Again, there are 3 categories that they say, which is contact, droplet, and airborne. However, there are kind of shared things too, right? So I have an airborne and contact sign here. That would be for chickenpox. You would still need airborne because it is airborne precautions. But you would also want contact precautions as well. So rather than having two signs up, you can combine signage. We have access to signage if you need contact signs. When I worked at Saints, we had special contact precautions for those that had C. diff or norovirus. That way the staff knew it was imperative for using soap and water for hand hygiene rather than just the gel. And so we were able to identify that separately. Donning and doffing of PPE after identifying the appropriate transmission. You want to make sure that your staff are trained on how to put it on, take it off appropriately. Faye talks about, making sure you do demonstrations, making sure you watch them do train back demonstrations, and then doing audits while they're on the floor. So again, not having necessarily your IP or the director of nursing going around and watching because people get nervous and see them on the floor. It's good to have secondary people do these audits and do clarification on if it's being done right. You do need to train them to do the audit appropriately, but you want to make sure that there are enough people out there and you are getting a good amount of number of audits, depending on your size of your facility and how many isolation patients you have. So sources of infection in the healthcare facility. This is a stock photo of like a quote unquote ICU. Obviously all the shared equipment that is in that room is a high infection source. Sinks, Legionnaires, other water growths. Under the cabinets, if it's not under the sink, if it's not locked, people store things there and water drops on there and it creates bad exposures. Go ahead to the next one. So in our healthcare, we have the number one contact, right, is patients, visitors, and our healthcare personnel together. So patients, if you're in double occupancy rooms, or like Faye was talking about in certain skilled nursing facilities where they do ambulate a lot, the person who knows everybody by name and decides to go hang out with everybody in their rooms, that's a really quick way to spread something, especially like COVID these days. Visitors coming in, either that are asymptomatic and don't know that they have something and are bringing it into the facility, or are symptomatic and don't really care to tell us that they are and follow the rules. Along with healthcare personnel. In the past, for those who have been in healthcare for a while, you came to work dying. You were sick, you still came to work. And it was because we didn't want to leave our other floor staff shorthanded on the floors. We didn't want to create that hiccup in the normal flow of what we have in our units. This now is really turned on its head because we really need to focus on making sure that if you have symptoms of anything, that we are staying home if ill, that if we've been tested and we're negative and we're allowed to work, that we're doing the proper steps of wearing masks and protecting others, if that is the case. Springtime brings a lot of allergies. For me, it's fall. I have hay fever bad. And so the tumbleweed in Nevada does not help me at all. So I get drippy nose and, watery, itchy eyes. But I know that if I go to a facility, I'm going to protect the facility. Even though I know I'm negative because I've tested or whatever, I'm still going to protect the facility that I'm visiting. So you really need to start instilling that in your staff members as well. Air, water, food. So MERV filters. ASHRAE 170 is the newest update of the ventilation of healthcare facilities. Skilled nursing was added to that. So you need to make sure that your skilled nursing facilities have met that requirement of the filters that are within your building. And that requires talking to your facilities director. Each level of care has a different MERV requirement. And then it also discusses when they should be changed out. So, take a look at that. And then water management plan. Again, that's something that you really want to make sure that you are meeting with your facilities management team and talking about what. Oh, sure, Siri, I can totally say that. So water management, you want to make sure that you are meeting with your facilities director and team about what they are doing within your facility to make sure that you do not have exposures. My number one arch nemesis in facilities is fountains. I have a handful of facilities that have fountains and they drive me crazy. So identifying those risks and making sure that you're utilizing the proper testing or enhancement of your water supply. Faye talked about this as well, patient's normal flora. It can be good, it can be harmful though as well. So, you really need to take into account when somebody is in an acute care facility versus an LTAC or a skilled. They are at different levels in whatever their illness stages or disease process. They become higher risk, obviously the higher risk they go. So if they're in an ICU, they're a more critical care patient. They probably are more at risk from having an exposure to their own normal flora for changes. Whereas, somebody who lives in their own home, as long as they're keeping up on their health, they have a much lower risk of contracting anything. Fomite contamination. So these are your high-touch services or surfaces that, our organisms can live on. I have the clean and biohazard tag there. This is a method that you really want to start looking at in your facilities to identify shared equipment and how you are identifying what was clean and what wasn't. We get a lot of things that are in the hallways. One of the ones that we noticed a lot of is like wound carts. They'll go from room to room to room and they're never wiped down. And then they put the new wound, containment scenario for dressing changes on top of it, but it's never been wiped down from the previous patient's room. And a lot of those previous patient rooms could have been on contact or different kind of isolation factors. So anything that is a shared equipment, Hoyer lifts is a big deal. Especially I think nursing homes have a lot of Hoyer lifts because of their patient population. Making sure that you have a process on how to identify if it's clean or dirty and then being able to clean it if it's already in that dirty process. Procedures, devices, drains, and catheters. Obviously, highest risk as a healthcare acquired infection. Anything that we introduce to a patient's body increases higher risk. So the quicker that we can DC any of these devices or drains, the better off the patient is. So making sure that you have processes in place, depending on what level of care you have, to identify when a device was placed, making sure that you are doing, daily checks to make sure that it's still needed. And if it's not needed, we need a process to get rid of it as quickly as possible. And just because a device comes to you from another location does not mean we need to leave it in. We need to have the conversation about discharging it if possible. So sanitation and environmental hygiene. Obviously, we know red boxes, sharps boxes, and biohazard bags. Biohazard bags, man, the garbage companies made a killing off of us in the past couple of years with all the biohazard bags we had from COVID. It is not a requirement to put all of COVID supplies or things into biohazard bags. The requirement is if it's dripping with wet soil, body fluids, that is what goes in biohazard bags. Just because it is from an isolation room does not necessarily make it a biohazard, okay? But we want to make sure that we have process in place for cleaning and all of that and managing this process. And a lot of places you'll notice that the sharps box on the wall is over 2/3 full, which it should never be that way. And so you need to have a process in place on how to audit that too. If you identify that that's a risk, put a process in place to check that and make sure that it's changed in a more regular time frame. Environmental hygiene. This encompasses effective cleaning of surfaces, using appropriate products, decontamination, again, of medical equipment and devices that are used in patient care procedures. So making sure that your EDS staff, your housekeeping staff are aware of that process and making sure that they not only know the cleaning process and disinfection process, but that they also know the PPE that they should be using to protect themselves. So this is a great tool from the CDC. It talks about how to read the disinfectant label, making sure that you know where it can be used, what it is effectively kills against, the kill time or wet time in the state of Nevada. That is a very difficult standard because we are very dry. Lately, our humidity has been a little better. I want to say yesterday it was like 60%, which was weird. But we are very dry because we are a desert state. So that wet time or kill time needs to really be paid attention to. Wiping something and walking away, you are not going to get that proper kill time to kill that organism. So making sure that your staff know what that means and know how to express that will bode well for survey purposes. And then utilizing the clean to dirty method. Again, following, these are all CDC referenced factors that you really just want to make sure every room is laid out differently, every facility is laid out differently. So whoever is the EVS manager really needs to know what the process should look like and educate their staff to following that so that you do get that proper cleaning. And again, so dirty to clean, top to bottom, and you want to create that pattern, and then you are able to prevent recontamination by doing that. So components of a multimodal stage for successful implementation of change. So this is a really big deal when you want to make big changes in your facility. Okay, so if you identify a process that needs more education or is struggling, utilizing this model is a much better mean for success than trying to just make a bunch of random changes. So if you can go to the next. So first off, you have to build it. So you have to make the system change. Either, you have to identify that need of improvement, research evidence-based practices, include clear instructions on the changes that are to occur. Maybe it's updating a policy. Maybe it's not. Maybe your policy looks great, but the staff aren't following it. And so being able to make educational changes to follow the policy better it might be what's required. So as an example, a nurse-driven Foley catheter removal process. If you are seeing high catheter utilization rate. And then make sure that you are capable of including it in your EMR if you have an EMR system, or whatever order process you have in the facility, make sure you're able to include that in. And then I always like to make this side one, make sure whatever changes you make, include that in your downtime paperwork. That is something that when you go offline, if it's a big winter and we lose service, then you have to go to paper charting when you haven't been using paper charting in a really long time. Having the new process in that downtime paperwork is really important. Training and education, so teach it. So you built it up, now you're going to educate to it. So create integrated education for staff affected by any changes. So it could include all of the staff. It could include just your nursing staff or just your CNAs or just your EVS. But specific, you want to make sure that you are getting the education target out to all that are included in that change, and make sure that it's education appropriate. So what you would educate a nurse to on a change, you might not educate an EVS worker to on that same model. You would want to make dedicated education paths for them, just because they might not know the organism names, or they might not be as familiar with the practices that the nurses are doing at bedside. So they need to know a different path for that same education. Check it. Monitor feedback. We want to make sure that once we've educated to it, that we have a process to verify that it's being utilized right, and make sure that you're able to see who is excelling and who still needs some further education. Maybe you need to do some more one-on-one competency-based education based off of what you've already introduced. Communications and reminders. So this is where you sell it. So this is where you get more staff involved. You want to get your higher level people within departments. So the supervisors, maybe even your chief nursing officer or others involved, to make sure that you are continuing to highlight the changes and make a relevant placement to it. So if you have a meeting every day in one of your rooms, maybe post it there so that people every morning when they come in, for certain leaders, they know there. But then you might want to put it in a break room as well, because then that gets other staff members that don't meet in the same meeting every morning. And then lastly is the safety, climate, and culture change. This is where we live it. This is where we engage all leaders and champions of staff to really drive that change home, organize meetings and focus groups, discussions with all the right people. So, if we're focused on just nurses, or just CNAs, we want to get their leaders involved, but we also want to get some nurse champions to be able to back up what they're doing so that they can reach out to somebody on the floor if they have questions in the moment, because the education person might not be available all the time. And then engage senior leadership and management to issue messages of support on a regular basis. Leadership engagement is the biggest key factor in making change. If your leadership is engaged in learning the new process or wanting to create a safer environment, you will have better outcomes on the floor just alone because of that engagement. So make sure, especially as an IP, that you engage your leadership when you want to make changes so that they're aware of what changes you want to make so that they can then support you on the back end. So HAI surveillance. So HAIs are infections that people get during the process of receiving care in a hospital or other healthcare facility. The HAI is not present or incubating at the time of a patient's admission to a healthcare setting. The surveillance is the ongoing collection, analysis, interpretation, and evaluation of data. And this is what we really want to be focusing on to build our quality metric standards, okay? And then healthcare surveillance is the ongoing systematic collection, analysis, interpretation, and dissemination of health data. So just because you have the data, if your staff don't know about it, it means nothing. You really have to make sure you're explaining the data to people that you're collecting information on. And that includes in your copy meetings, in your IP meetings, you're educating and you're talking about what you're seeing from the collections of data that you have been receiving. So conducting surveillance allows you to provide baseline endemic infection rates. So again, going back to Faye's topic of the PPS testing of CRS, that's a baseline. If we're testing a large unit or a high risk unit, or even the whole facility to get a baseline on what our CRS cases look like, that's the starting point. And from there, then you create other surveillance factors to monitor that we don't have growth and that we hopefully decrease that path. Unfortunately, when it becomes something like down in Vegas, we need to also accept patients that have all these multi-drug resistant organisms, but we also need to do it in a safe manner. So just because we know that we have a baseline of a certain number, if we're going to accept patients, we know that number is going to still increase by accepting patients, but it's a known hazard at that point. So you should then be able to create a safety module around that particular patient or particular population to keep the rest of your residents safe. And then you can identify increases in infection rates, so clusters or outbreaks, provide information on the occurrence, the incidence or prevalence, evaluate efficacy of control measures. So, going back, are we doing good hand hygiene? Are we doing good wound dressing changes? All of those really come in. Go ahead. So types of surveillance, you have active surveillance, includes having trained individuals such as your infection control person looking for cases of HAIs. So examples are review of microbiology reporting, Foley catheter insertion and care, actively going in and watching them do the insertion and care of a Foley catheter, central line insertion and care, wound care, and then again, I put Candida auris screening on here. Passive surveillance is a kind of surveillance that is based on constant information gathering. So examples would be, doing your audits on transmission-based precautions. Are the proper people on the right precaution model? Your PPE compliance, the staff that are entering those rooms that are on transmission-based precautions, are they doing PPE? Are they doing it right? Environmental services, cleaning and disinfection. Glow germ is great to have in your facility to identify if your EVS staff are truly hitting those markers. And then any process that needs improvement, hand hygiene, the list goes on in healthcare, unfortunately. It's a never ending list. Yep, you're good. Okay, you're good. So presenting the data. So it's great to have numbers, and numbers are awesome. But numbers don't mean anything to people at the end of the day. You really need to present it in a meaningful manner that's easy for them to digest. Graphs, to me, hit the mark pretty much across the board. If they can see comparatively by unit or the whole building. We went from, every January, for some reason, we have an increased rate of C. diff. Why is that? Then we can pre-plan before January to start having some models and education done so that maybe next January we don't have that problem. If we see that, June of every year, we're shortage of staff, so then we start seeing, other scenarios like UTIs occur because we're not doing proper peri-care because we don't have the staff to do that. Those are areas that we can then talk to leadership about having backup plans as to when that comes up. Along with that, we can also get or create buy-in from staff by pitting them against each other. So if you have different hallways, a little, competition goes a long way. Nobody likes to be on the bottom of the list. So, everybody knows that, one unit has amazing hand hygiene audits. Now, mind you, we don't want inflated ones. We know people will say they have 99% compliance rates on their unit, and that's not the truth. So we really want to get real numbers here. But at the same time, we do want healthy competition between different staff levels. If it's CNAs versus nurses on PPE compliance, that's a little boost to get people to do better PPE compliance. So infection prevention practices. Infection prevention obviously is a practical evidence-based approach preventing patients and healthcare workers from being harmed. But the first stop to stop the outbreaks, you first have to have a plan in place. So to build a plan, you have to know our risks. We have to build our risk assessment, and we have to include everything from the community that we live in, which includes state and federal regulations, procedures, devices. What do we do in our building? Hospitals might do surgical infections or surgical services, not infections, hopefully. But skilled nursing facilities aren't going to do surgeries, right? So that wouldn't be on your list. However, it might be something that you have as a lower number on your list because you take a lot of patients following surgeries. Maybe that's part of your intake plan. So that's something that you need to understand. If you don't take central lines versus you do, or if you have a vent unit or you don't, that wouldn't be a requirement for you to risk if you don't even have them in your building. Prevention activities, so your PPE, your hand hygiene, cleaning and disinfection, your environment of care, which includes water management. Environment of care also includes, for those who work in hospitals and have Joint Commission surveys and such, they come around and they look at one ceiling tile and they say, oh my gosh, you have one ceiling tile that's brown. We think that could be a leak. And oh, we saw another one, so now it's like everywhere, right? That still includes in skilled nursing. We want to make sure that we don't have those issues. If there are holes in walls, that's an open area of opportunity for growth. So we want to make sure that we're looking at those. Policy procedures, your IP plan, your COVID-19 plan, an emergency pandemic plan, all of the above, water management included. Preparedness, emerging infectious diseases. So for up here in the north, I would actually include auris on that line listing because we haven't seen the rate, obviously, that others are seeing. So we would want to treat it as an emerging scenario and want to educate to that so that we're really at high alert so we don't end up having scenarios here. Employee health, which goes over vaccinations, sick policies, MDROs, and other identified risks. So I sat on IHCC for a couple of years, and one of our identified risks on our risk assessment were zombies, just because it was fun to add it to a risk assessment, because at the time we were training for Ebola, so we thought zombies was right there with that. So, if you want to get fun with your staff and creative, it's always another area of opportunity to include them in some changes. Assign values based on risk. So your probability of the event occurring, the impact severity, what it has to your service line, to threat of life, to financial loss. We know that COVID was expensive. Lots of PPE creates a lot of expense. However, if we don't use PPE appropriately and we have a high death rate, that creates another risk for our facility. Our current system, what do we currently have in place? Our systems, our training, our policies. Rank order of risk. So we want to make sure that we score them all and identify some of your risks
should always be at a high risk, even if you think you're doing great, depending on if they are mandated reportable to NHSN. So for acute care, CLABSI, CAUTI, C. diff, those should always be ranked at a higher level, just because we still have to monitor them at all times and they are reportable. So they should always stay. So for skilled nursing facilities, it would be CAUTI, that is state reportable into NHSN, and C. diff. So those would be the two. Even if you feel that you're great on those areas, you would still want to keep them as a higher number. And then that is the AFIC risk assessment tool, and it is fillable. And I have the link for that later. So then you have to write your IP plan. And based on your prioritized risks, you want to make sure that you include measurable goals, include strategies for implementation, and that your plan is written and evaluated at least annually. If there's something that pops up in the middle of the year and you need to make changes to that plan, that is completely fine. But per CMS standards, you have to make sure that you are at least reviewing it annually and making changes regarding that plan. So again, writing your IP plan, you rank your priorities, you use your top risks, highest risks to set your goals. Your goals are broad statements. Don't go too deep into it, because that'll be what you do when you create the change plan, right? Develop measurable objectives for each goal. Don't say, you know, oh, we're at 42% for hand hygiene, so in 3 months we're going to be at 100%. That's not an attainable goal. We really want to make sure we get lasting change and not just a quick, let's do it now and let's forget about it in the long run. So make sure that that you have those objectives for each goal and that are measurable. And then design steps. Woo! Thanks. Design steps, strategy to meet those goals. And then determine how you will measure success. So what that goal looks like to you and to your team. So risk assessment and plan is done with interdisciplinary input. Now, this is the biggest thing, especially for skilled nursing facilities. IP is still a new thing as being pushed, and particularly group homes and assisted living. They are not lone wolves in the building. They should not be doing this all by themselves. We need input from all areas of the facility to make sure that we're hitting all those goals, and to make sure that we have the support, because you cannot be there all the time and you cannot fix everything. So we need to make sure that we have medical providers involved, administrators, nursing, environmental services, facilities, other leaders, maybe corporate leaders that you have available to you. If you have your own employee health, or if you're utilizing an outside employee health, you'd want to collaborate with them as to things like that. Skilled nursing as well doesn't have internal pharmacies or labs. So you want to work with those partnerships as well to make sure that they have input as you make changes. Pharmacy, antibiotic stewardship. So the same steps taken for writing an IP plan should also be taken when writing an antibiotic stewardship plan. You want your risk assessment, your goals, measurable objectives for goals. One of ours years ago was our fluoroquinolone use. We really wanted to make sure that we were managing that appropriately. And that took a lot of time. Our pharmacist did a lot of research on all the patients that were on fluoroquinolones on a regular basis. Would call the physician in the moment and have conversations as to why, if it was necessary, or if it didn't meet criteria, and then offer a suggestion as what else could be used. Again, that is a little bit more difficult for skilled facilities or assisted living facilities that don't actually do a lot of medical care. They have an outside health agency that comes in, but working with your partners is really needed. Making sure that you are able to get antibiograms from your lab people is huge. And then obviously, again, interdisciplinary team, you want to make sure that you are utilizing all your partners when having these discussions. And that is it. So we as IPs can make changes. It takes time. We are very repetitive. You will get asked the same question thousands and thousands and thousands of times, and sometimes by the same person. And that's fine. You have to still put a smile on and still continue to educate, because that is our role. But we just want to make sure that you know that the state is here to back you, from the HAI side to the IP side. We want to be of any help that we can. So thank you very much. Any questions?
Thank you, Jen. Any questions, north, south, or if you're virtual, place them in the chat. We'll read them off.
Good. I would like to say, point level.
You did, you were good. Nothing from up here. I don't think, no.
Nothing up there? Okay,
Correct.
any questions in the South? I guess you were very thorough, or everybody's ready to go to lunch.
Yeah.
Is there
it's
anything in the
lunchtime,
chat,
that's what it
Shreya?
is.
Are there any questions in the chat? Alrighty. Well, I do want to give you Jen's background because I was trying to hurry up and rush and forgot to do her intro. So Jen does work with the Nevada Bureau of Healthcare Quality and Compliance. She's a health program specialist one, who is focused on infection prevention education with the state of Nevada HCQC. She's passionate about patient safety and improving outcomes for patients, staff, and the community at large. Prior to working for the state, she was the IP coordinator and then the IP for St. Mary's Regional Hospital Center, Regional Medical Center for 6.5 years. And during her time at St. Mary's, she improved overall hand hygiene and PPE compliance amongst staff, providers, and visitors. Her biggest accomplishment during her time at Saints was building an Ebola plan where she worked closely with Washoe County Health Department, the CDC, and you work with me, Jen. You forgot me on here. To become a Ebola transfer facility. That was a lot of work. And the hospitals had to create these huge binders to be transferred facilities for Ebola transfer. So thank you, Jen, for your wonderful presentation. We will break for lunch. I can't see that clock. It's 12. I have almost 12:10, so we'll come back in an hour. I do not believe I can secure this room, so if you have any laptops, things like that, take those items with you, and we will reconvene in an hour. So I'll say be back at 1:15. For lunch, yes.
Sorry, I just want to interject really quickly. During Faye's talk, she talked about enhanced barrier precautions, and I just want to remind everybody that is only for skilled nursing facilities and below. So LTACs do not qualify in the enhanced barrier. They are considered licenses in acute care as well.
Great, thank you for that. For Truckee Meadows, there's a cafe on site. I was told that the food facilities are a little far. So if you want to stay on site, Chrissy can direct you there. If you're here in the South, if you go back, I'm not sure which way you came in, but this is McDaniels right here. So if you go back to Civic Center and make a right this way, at Lake Mead and Civic Center, there are a bunch of eatery places. I believe you make a right-hand turn, you'll see everything on the left and right-hand side of the street on Lake Mead. So see you in an hour.